So let's maybe do some introductions. So Amelia works for the Cancer Alliance, and she has helped us put this sort of show on the road. And the webinar today is centered around both Claire and Federico. So I'm just going to introduce both of those so that those people, thanks so much for joining us, Claire and Federico. So I do want, so Claire, you're clinical CNS specialist for head and neck at UCH. You're going to be talking about the our urgent suspected cancer triage audit, and Federico, you're an ANP head and neck as well, plus ENT and thyroid at UCLH, and you're going to be talking about referral optimization and messaging support. Is that right? So thanks very much both for joining us. And then we've got Sabina Khan, who's our Macmillan consultant, head and neck therapeutic radiographer, and so she's also going to be talking about late effects. So I think what we'll do is we'll start off, and we're recording this session. I hope that's all right with everybody, so that we'll be able to have that on our channel for people to look at later. And if you need to, we can always follow us up with a repeat webinar if the timing doesn't suit people to communicate with us about that. Okay, so myself, as I said right at the beginning, I'm Claire Stevens. I'm a GP in Barnet, but in this role, I'm the co-clinical director of the North Central London Cancer Alliance. So welcome, everybody. Thank you. Okay, well, I think first of all, we're going to go to a bit of a conversation. And this is a conversation, so please, you know, butt in, raise your hand when you like, about to talk about the pathway. So I think both of you together, Federico and Claire, on the early part of the head and neck pathway, and including kind of common things that we need to consider as in primary care, how we're looking at referral optimization, and how Consultant Connect will be working for us locally. Thank you very much.
And I would say so in the part after that, we'll be moving on to Sabina, who's going to cover late effects. Yeah, so we've got everyone here.
Thank you. Whoever wants to start, please start.
Thank you. Amelia, are you going to share the slides?
Yeah,
thank you.
Yeah.
So so I'm Claire, lead CNS at UCLH for head and neck and thyroid. So I just wanted to start by going through, so in the head and neck team at UCLH, we vet and triage all the referrals that come in to us here on the suspected cancer pathway. In the CNS team, we triage all the under 50s. And so I just wanted to present to you our latest audit results. So we did an audit of 300 patients in the triage telephone clinic for the under 50s. And so what this showed to us was that the majority of referrals are laryngeal, pharyngeal, neck lumps, oral, ENT and thyroid. And so what we can see here is that I'm focusing mainly on the laryngeal, pharyngeal, because they are our majority. In the top row, you can see that 68% of the patients under 50s who we triaged remained on the cancer pathway. 31 were downgraded, 1 was discharged at triage. And so if you look down, majority of patients remain on the cancer pathway. However, in the next slide, I will go on to show that actually all of them end up being discharged. So some of the work we're doing around in the CNS team is increasing the number of patients who we downgrade off our cancer pathway. When we downgrade them, it still means that we still see them at UCLH in a face-to-face clinic, but they just go into a routine pathway of 6 weeks rather than getting an appointment within the next 7 to 10 days when they remain on the cancer pathway. Amelia, if you wouldn't mind going to the next slide. So of the 300 patients, no referrals had cancer. And so of the laryngeal, pharyngeal patients, 94% were discharged. 1 remained on the two-week wait cancer pathway. So myself and Federico are doing some work around these laryngeal, pharyngeal patients and how we can change things within the early part of the pathway. One of them is CNS advanced practice to downgrade more of these patients, to develop a straight to test strategy going into scoping clinics. all stuff to reduce the wait times for patients coming in on this pathway. And then if we go to the next slide, Amelia. So we did an audit of the patients. So these are of the under 50s who we put through, kept on the 2-week wait cancer pathway, who then were seen by a doctor in clinic, who were then discharged back to the GP. These were the outcomes of the advice given to the laryngopharyngeal cases. So a lot of them were given a prescription for Gaviscon and asked to trial PPIs for reflux. So one of the main things that we see causes for the referrals into our service are for reflux. We give throat care advice, steaming, a lot of advice around hydration, and then dietary advice around reflux. A big thing for us as well is often why we do keep patients on the 2-week wait cancer pathway is for reassurance. And then if patients are very anxious, we don't downgrade them. We do keep them on the cancer pathway. But then that coming back into sort of the team advanced practices and managing the anxiety around that. So I'll pass over to Federico.
Hi everyone, I'm Federico. I'm the advanced nurse practitioner for head and neck and thyroid. I don't know if you can share the next one. Perfect, thank you. So as Claire said, we talk about most of the cases that we see and that we triage as laryngopharyngeal cases. So I work in the head and neck cancer clinic alongside the doctors, and I see mostly laryngopharyngeal cases as well. I'm also part of the team that is involved in the triaging of these patients. In particular, pretty much all the thyroid referrals will come to me. So I'm going to speak about a little bit about thyroid and the way and the type of referrals that we should see. Okay. So here at UCLH, we created a different pathways. So just to make you aware, when we receive a referral, we can either send the patient, depending on the appropriateness of the referral, to an ultrasound straight to test, where the patient will be sent straight to one of our radiologists for an ultrasound. And then, depending on the result, they might have a biopsy or not, and we will see them in clinic to do a proper clinical assessment. But we already have the results. So in this way, we are cutting some time in the optimizing time in the cancer pathway. Another service that is really good, and probably some of you are already aware about, is the Thyroid One-Stop Clinic. So this is the diagnostic service that we run once a week. And basically, we're able to see a patient that are meeting the criteria, and our aim is to give them a diagnosis within the same day. So we can see the patient, do all the investigations, so ultrasound, plus or minus an FNA if needed, blood test, and then the patient will have an appointment in the afternoon that where we discuss the results with them. In the same day, we have the thyroid MDT, so we're able to discuss with radiologists, pathologists, and cytology, and then most of the time we're able to give a diagnostic result to the patient and make a management plan on the same day. Obviously, we have reduced lots, so not all the patient will get into the one-stop clinic. Some other type of referrals will be seen directly face-to-face, or they will be discussed on MDT, and I'm going to give you some examples. So type of referral, obviously, back to the previous one, thank you. As we probably saw in the previous email, we have a pathway for neck lumps in general, but it's important to differentiate. So please, because those one will go straight to test. But if there is a lump in the thyroid region, please, if you can indicate in the form, so we can actually make sure that the patient goes to one of these pathway and is more straightforward. Type of referrals that we see, we focus in particular on thyroid nodules and goiters. So we can see patients that had an external referral, usually, for example, in-health referral, that is showing indeterminate or suspicious U3, U4, and U5 nodules. So these patients will be really appropriate usually for one-stop clinic if you have availability. Some other things are we get many referrals for patients with incidental findings on other scans. It's very common, CT scan, MRIs, or PET scan. Obviously, a PET with the FDG avid thyroid nodule will get, probably will be booking one-stop clinic if it's possible, because it's a little bit more higher risk. And then we also want to see patient refer for second opinion. We're getting more and more of these ones, probably as the service is growing with the one-stop. And patients who have been treated previously with thyroid cancer as well. We get many referrals for patients that had diagnosis done abroad, and then they come back to us, or patients that need further treatment, such as radioactive iodine, or needing follow-up post-cancer diagnosis. Please, just something really important, if it's possible to always attach all the reports that are available. So, because otherwise many times we lose a little bit of time to try and track it. Our admin is really good, but it would be good to have all the referrals in the attached file. So if you can move to the next one, please. Yeah, thank you. So one really important point is that, as we said, we see many laryngopharyngeal cases, but we also get many ear and nose referrals. Some of them might be appropriate, some of them not really. And in that way, I know that the all London, the form is really general. So it's pretty straightforward to tick like ear pain without known cause. But just to give you some example, we went through with some of the doctors. So mostly we want to see refer ear pain with throat or neck symptoms. Okay. Some cases that we tend to see still in clinic, and is a bit difficult to let's say not accept because of the nature of the 2-week wait, is patients with the obvious infection, for example, with ear discharge that is known, they're already on treatment, and they have ear pain. Those ones should be referred to otology. Earwax, rare, but we still get this type of referrals. Sudden sensory neural hearing loss, SNHL. Cholesteatoma, we tend still to get some of this referral, but the cholesteatoma is a benign entity, and it should be referred to the otology. Usually the treatment plan is with them. And then many cases with the bilateral tinnitus in particular should go to the otology, and bilateral clonic hearing loss. In terms of nose, I know that is a bit tricky because the view might be reducted, so restricted. So what we want to see mainly referral for unilateral nasal polyps, persistent unilateral nasal blockage. We want to make sure there is nothing in terms of nasopharyngeal cancer. Epistaxis can be a presentation, but obviously it's up to the clinical judgment to see if a patient is the type of epistaxis for the benign ENT or not. But some cases that they should really be referred to rhinology are chronic nasal symptoms, allergic rhinitis, and known history of nasal polyps. Usually they undergo treatment with the rhinology team. If you can move the next one, please. So what we were thinking, so we've done some work here at UCLH. So obviously, once the referral is done, it's very difficult to have, and I'm going to talk about the advice and guidance NHS digital. But before a referral is done, if you're unsure, we are using Consultant Connect, which is a really, really great platform. Basically, it can give direct access to specialist advice. We will get most of the referrals is either me, my colleague, and we can run it to the doctors if you're unsure. But then it gives you pretty much the opportunity to upload photos or images, for example, some forms, a referral or reports for ultrasound scans, very helpful. And then we can review it. We receive a notification on receiving requests straight away, so it's pretty easy to track. And one thing that is really important, I know we're busy, we move around, but there is a mobile app that is available, and it's very simple to use. It's really good on the phone. I use it all the time. and it's pretty much the same thing. I'm going to show at the end of these two, I'm going to share the main page. The other one that I want to ask when we open for questions is, so I've done some work, because basically the main platform that we use is 2 week wait for 2 weeks wait referrals is ERS. Now, I want to know from some of you your experience, if because we don't tend to use it, and I went through and I'm going to show you, is it would be the easiest platform to have recorded, conversation with a specialist, for example, where you can go back and check again to see what was the outcome of the advice. So it's available on integrated ERS. Okay, it's pretty easy to check and review the outcome, and it gives you a feature to add documents or reports. One really important thing is that the advice and guidance response can be held on the work list for up to 6 months. So you're always able to track back, in particular if it is a different GP, and then you can select the patient. So now I'm just going to share the main page of Consultant Connect very quickly, and then I'm going to show you. Just let me know if you can see, and if I'm sharing. Amelia, can you see? Yeah. So this is the main page for Consultant Connect. As you can see, obviously you need to do your account, and then it will give you some options. There are so many different tabs for to understand how to use it. Okay, there is a guidance, advice and refer platform, and then telemedicine devices. It can be also used for patient-initiated follow-up, but this is something that has been built up as we speak. And then I just want to, let me just stop this sharing, and I want to show you this one, which is second, because it would be really interesting to see if who is using this, maybe for other specialties, and let me know if I'm sharing okay. So this is the part of the NHS digital plan. Okay, so for all the GPs that most of you are using ERS anyway, and this gives, is a guidance to try and get some referrals advice before you send a referral. It's really easy to track. As you can see, you can put the NHS number, then you select the patient, and then you have different options. You can select the advice option for request types section, and then obviously it will open different tabs. Now you can select if you want advice or if you want a referrals, the type of advice that you want, if it's routine, urgent, or probably a 2 week wait, and then you can select the service. So in this case it would be head and neck or whatever service you need to select. In our case would be head and neck ENT. And then so this as you know, probably Amelia, if you can share the link on the chat, it would be good to see who is using it, because it's really important. We can share image and we can share report. It might be much easier. Usually you need to go through the admin of the GP practice and try to get the referrals and the report. Sometimes we're missing some reports in order to make good triage. Okay, and then at the end you can see the different options that it gives you, and you can review the response. You can see if the referral has been accepted. Okay, but it's a way that is really important, and probably we can build it up, because we don't really use it at the moment for 2 week wait cancer referrals. I went through it, and it would be good if you think it's helpful, which I think it would be in the future, to create this kind of advice platform here using this service, because it's easily replicable and trackable for each one of you, as long as as long as you know the patient. Yeah, I think that's it from me. I think we're gonna have questions at the end, Amelia, if I'm not wrong, after Sab's presentation. All right, thank you.
Hi, can you see my presentation?
Yes, I can see them.
You have to excuse me, I've got a bit of a cold. But my name's Savina. I'm a consultant therapeutic radiographer, and I specialise in head and neck laser fix. So to give you a bit of a background, bear with me. So we know patients are living far longer, mainly due to the success of improved survival rate through novel treatments, advanced treatments, early diagnosis through processes like, as Federica has highlighted here as well, and just recognizing the signs and symptoms early enough. But we're in the position where patients are almost dealing with the consequences of our successes. So patients are living far longer, but actually they're seeing more and more side effects associated with their treatment rather than the cancer themselves. So here at UCLH, we're in a bit of a weird space because we are the primary surgical provider for head and neck, not only for the North Central London Cancer Alliance, but some parts of the NEL. But patients can see a surgeon in terms of the initial referral, but have initial surgery or go on to have radiotherapy, immunotherapy, or chemotherapy, or could just have any of these as primary treatment, really. But then if they have surgery and have post-operative radiotherapy, they can go on to have it in several different centres. So in the NEL, it would be Barts or Royal London, the Queen's. But in the NCL, it will be through the Royal Free with North Middlesex or here at UCLH. But we have this weird circumstance where we are one of 2 centres that provide proton beam therapy. So we're in the position where anybody who has head and neck cancer and fits the right profile can be treated here at UCLH from Birmingham down, basically. But to understand what happens in the late effects, it's really important to know what happens at the beginning of the pathway, and it makes us understand more of why these patients are struggling post-treatment. So as Federico says, we are really good at screening patients and seeing who should be done on the 2-week pathway. But once patients are diagnosed, it's a really, really fast turnaround. So what happens in reality is a patient will be said will have a confirmed cancer in an MDT on a Wednesday morning, possibly consented on a Wednesday afternoon, meet the clinical nurse specialist, have their teeth assessed. Quite often, several teeth are taken out before radiotherapy, which can be quite traumatic, and then have multiple different tests, have this plastic mask made, and you're told, oh, it's not very claustrophobic, but it kind of is, and it has lots of holes in it so you're able to breathe. So we're trying to reason with it, and then when you see it, it's a bit of a shock to the patient to realize what was happening. And then they have this weird waiting time of about 2 weeks where the plan is being produced. And that's really necessary because without such precise planning, we're unable to treat to millimeter accuracy. But in the patient's position, they're waiting 2 weeks to have a treatment done where they're literally pinned to the bed, have a machine moving around them, and they have to stay still for, depending on what treatment you have, for about 15 minutes. So all of that happens really, really fast, and then the treatment happens over 30 days. And then on top of that, as the treatment happens, you get quite significant acute side effects that makes the reality of the cancer prominent at that stage. So when we're thinking about toxicity and side effects, acute side effects are usually disappear within the first 6 months, and they tend to be skin reactions, which is very common, or mucositis, problems with dysphagia, swallow function, and pain. But after 6 months, we're left with a whole range of side effects that we need to deal with, and some aren't even mentioned when we look at follow-up. So when we think about late effects, what we're really defining it as is anything that occurs after 6 months of radiotherapy, because we know anything that was in the acute phase should have recovered by then, or if something occurs well after the radiotherapy. And that's really key here, I think, as a GP. It's really difficult to know what could be because of radiotherapy 10, 20, 30 years afterwards. But unfortunately, radiotherapy is the gift that keeps on giving. So many of the side effects that are happening is because of radiation-induced fibrosis, and that could pretty much happen anywhere within the head and neck field. So just because you were treated, I don't know, for a larynx, it's not a short field, it could be a huge field, it could be right up to the top, right to the bottom. The radiation could probably be clipping around the lower edges of their neck. So it can cause all sorts of side effects. But actually, as a GP practitioner, as a GP, it's very challenging for you to understand the nuances around radiotherapy without us being clear and concise and accurate with what we have actually treated in the first place. So when it comes to late effects, actually, there's loads that are in there in the literature, but some are really underreported, if not reported at all. And actually, if you think about it, the problem we have at the moment is that we're seeing each symptom as an individual thing. And what we need to do is start treating patients much more holistically. So if we realize that each symptom or a bunch of symptoms can affect patients emotionally, physically, and psychologically, we'll probably get far better outcomes. And when you think about late effects, we do consent patients for it. But if you're that person that's been told a life-changing diagnosis, you're going to sign any form at that stage. And equally, look at what we consider as rare. So what's less common are things like hearing loss, osteoadenocrosis, swallowing problems. But actually, in my practice in the late effects setting, so we've been up and running for about 18 months now. the most common thing we see is hearing loss and swallowing problems, and we have had quite a few cases for osteoid necrosis. So I think what we're trying to challenge is what we think is rare, what we sign off as rare. For that patient, when they get it, it doesn't actually matter. It's just early diagnosis is key. But the things as a GP practitioner that you most often see and should probably be screened really after radiotherapy are things like hypothyroidism, which can happen at any point because quite often the thyroid is within the radiation field. Trismus, which is really challenging for those patients, can have a huge knock-on effect. Dental problems for sure. So for anybody who's had high dose radiotherapy of doses above 40 gray to that region, they should really have specialist treatment for any teeth that needs to be looked at because they have a higher risk of osteoid necrosis. But the most common things we see in our clinic are things like dry mouth, altered taste, lymphedema, and actually, I haven't actually seen that much skin color change weirdly at the moment, but it's one of the things we consent for late effects. So it'll be interesting to see the data on that now. So what can a GP do to support patients? Well, just remembering the fact that this patient had head and neck radiotherapy. So if anything occurs within that radiation field zone, which we should be giving the information about, then there is a high possibility it could be due to that. So if someone has swallowing changes or even a chest infection, if we think about aspiration with late effects because dysphagia, that could be because of their head and neck radiotherapy, even 10, 20 years afterwards. And we've had to put in enteral feeding methods for several patients well after they've been discharged from oncology. Symptom-specific management, the reason why I put that on is rather than seeing just a symptom, look at the knock-on effects for that patient. So when we have patients who have nutritional needs, actually it's far beyond just eating and drinking. It usually impacts them significantly socially because so much of our lives revolve around eating, drinking, family, and the knock-on effect of that is not trying challenging foods, not getting the right support, not seeing a speech and language therapist in the first instance rather than an oncologist. So things like that. And just providing much more holistic support because understandably, it can be really challenging to treat these patients. So rather than having an MDT, rather than having a single person look at it, it might be preferable to have an MDT approach, which is where the late effects setting comes in. And ongoing monitoring referrals. So whilst we know that patients can have things like hypothyroidism, screening regularly is really key because it can happen at any point in their survivorship journey. So really what we need to do is shift our thinking from a head and neck patient to this was a person treated for head and neck cancer. And as you can see here, the radiation field can go really high to really low. So for us to empower you guys with the information to know what we are actually treating in the first place. But for us, the key change from running a service here is that we run mainly on a patient-reported outcome service. And the reason for that is in the survivorship journey, what we found was where clinicians reported things like altered intake, moderate symptoms, the patients were saying, what does that mean for me? And it had us questioning, what do they need? And in reality, if you see what that patient has using a PROM, it's quite easy to see that it has a huge knock-on effect on their quality of life, in relationships, sex, work, eating, sleeping, fatigue, taste, and enjoyment of life. So we chose this PROM, so it's the MD Anderson tool, and it's great because it basically has all the main late effects apart from hearing loss on it. It has a 0 to 10 scale, so we use it as a PROM screening tool, but also a measure of success, and it has a great quality of life outcome at the end as well. And using something like this, you can see how a patient who might just have fibrosis actually has neck stiffness, can't turn their head, are unable to drive, lost their job, had an impact on their income, affected their sex, relationships, knock-on effect of lymphedema, pain, dysphagia, and what could happen in the future too. And what it does highlight is the discrepancy between what can be offered nationally. I know we've got things like a lipo stem cell transfer that we can offer here at UCLH through Royal Free, but actually up in the north in Nottingham services, they can offer things like photobiomodulation, which we just don't have access to at the moment. So really, just to understand what you guys can do, we need to understand how this late effect service came about. So we are the only solely head and neck late effect service in the country. And unfortunately, it's run by just me at the moment, which is all we have funding for. But so it's a consultant therapeutic radiographer led. And the reason for that is I've had over 10 years experience within oncology and radiotherapy, and actually understanding where the plans are, where the dosimetry falls, and relate it back to the clinical findings is really key in making this a success. But actually, we need to work together with primary care and all sorts of services, because when patients are discharged from oncology, it's not oncology and surgeons that are going to be seeing these patients. These patients are going to be picked up by GP practices, by community services, community SLTs, occupational therapists. And really what we need to do is create a sustainable service that we know that we can carry on. So it was supported by the oncologists and an amazing head and neck UCLH MDT. I think every single person has been really supportive of it for the last few years. And what we've managed to do is tap into primary care networks far and wide. So we've managed to go in even to places in the NEL, looking at community speech and language therapists and what their challenges are, because actually these patients are competing with SLT slots for patients who had strokes and things. So to understand the nuances involved in primary care. Also, finding somewhere to do this was an absolute challenge because there's no room anywhere. But actually, what I could point to you guys is, do we need to do this in a hospital setting? Could we branch out and maybe create satellite centres or maybe work with GP practices to be able to facilitate this as well in the future? And we need to make sure we collect the demographic data, because the patients that are in the literature aren't the patients that we're seeing. So we know in the North Central London Cancer Network, we have a significant proportion of patients who are from the Southeast Asian community, from Eastern European communities and several different communities. So the advice that you give should be altered towards that person and provide personalised care. And the example I always give is telling an old Bengali lady who's eaten a certain type of food her whole life to go and eat mashed potato. It's not going to work. You're not going to get the outcome. All you're doing is giving the same advice to a blanket type of patient. So really, we need to personalize that care. I did have Simone for a bit, who was funded by the North Central London Cancer Alliance, but unfortunately, his role has finished within this as well. So we launched in 2023, and so far we've had over 230 referrals. We've managed to see 161 patients in that time, and we're currently on a 4-month waiting list. So that's really key here, because when we are giving referrals to these patients, just to manage the expectations that it might be a little while before they're seen. So the service so far, 40% of patients actually need further GP support, and that's because of the ongoing support post-treatment, quite often thyroid concerns, endocrine concerns as well. 80% of patients needed nutritional support, but actually only about 10 to 20% of these patients actually needed a dietitian. We were able to do this in-house. 63% of patients needed speech and language support, and again, this was done in-house. Only very few patients needed referrals, but for the few that were post-oncology, they needed to have their speech and language therapy done in the community, so we had to tap into those systems. And interestingly, a few patients needed PEGs put in well after their radiotherapy journey. I think the latest one was 12 years post-radiotherapy. 25 patients needed mental health support. We don't have the capacity to do that here after 5 years, so we're reaching out into the services that are available, but also community services. Don't underplay what can happen when you reach a community service, because actually they can provide that support that they need. And what we also did was create our own head and neck late effect support group, where any patient who's been treated for head and neck cancer with radiotherapy can be referred to. 60% of patients needed sleep support. We managed to find 4 recurrences within those first 400 referrals, which is rare actually, because they're usually picked up within the first 2 years, and one of them was actually at 8 months, and another one I think was at 1 year. 3 new cases of osteonecrosis, which is really key because in the consent form it's a rare side effect. We had loads of support from the occupational therapists who have been great into rehabbing these patients back into the community. 60% of patients are still working, and that's really important because we want to get more people working. And essentially, these patients want to keep working. The impact of cancer financially on the patient's lives is massive. So really, if we can get them back to what they think is going to create that better quality of life, then why not? Now, 16% of our 16 patients needed Botox to their neck to help with spasms. 32 patients were on trials. 7 patients actually needed deprescribing. Quite often, patients are just left on long-term pain meds, understandably, but actually, whilst we adjust and use things like exercise and occupational therapy support and physiotherapy support, we've managed to minimize the need for pain medication. And 30 patients have been referred for lipotransfer to help with fibrosis of the neck. So here is some of the qualitative feedback that we've had. And what was really, really interesting is that patients were happy to move on with their life and be discharged from oncology and surgical pathways if they knew there was a way back in. And I think that's where we have to work with GP practices to make sure that we have a really good route in. And our referral pathway is very simple. We followed the North Central London Cancer advice, where we should be having a health professional and patient self-referral route, mainly health professional, but actually can be any health professional that's seen somebody who's had head and neck radiotherapy, as long as they've been treated radically and had minimum 6 months post-treatment. And as a GP practice, all you have to do is just email us with some of the details, and then we'll triage it from there and then offer face-to-face and video clinics. But what happens is we use the PROM screening tool as not only a method of entry, but also a method of self-supported management, and that can then be fed back to GP practices as patients use them. And what we're trying to create to help the GP practices to, give advice appropriately and understand what actually happened during the radiotherapy, we're trying to create better head and neck late effects summaries. So summaries to highlight to you where the radiation actually fell within this patient. So this patient had a parotid treatment, but in reality, the treatment was just under the orbits, right down to their clavicles. And actually what type of exercises we recommend, what should be done as maintenance exercises and what should be done as a rehab exercise. But obviously, it's really hard signposting patients to the right place. So what we've managed to do is get funding from the Oracle Trust. And what we're trying to create is a national best practice guidance for late effects of radiation treatment to the head and neck. And we've got an amazing group of people who've come together. And we're hoping this is going to be published by the end of the year next year. And then hopefully that can help guide you too. So in conclusion, what we need to do is educate and empower each other to understand each other's methods of treatment, the support that we give, and maybe work together to create a much more efficient pathway, create better end of treatment summaries, create personalized care to make sure that the patient's needs are met properly, introduce things like prehab and rehab, refer patients earlier enough so that we can get the best outcomes. So if we think about lymphedema, the earlier we get in there, the better outcomes we're going to get. MDT working, and that's cross-working with primary care and hospitals, I think. Introduce new things like social prescribing and look at national services. So we quite often work with the Clare's pain service up in Bristol, and they require a 2-week stay, but actually we've had some great outcomes from it as well. So in terms of referrals for GP practices, what we need is somebody who's been treated at least 6 months ago with radiotherapy. They're no longer on active treatment. They had curative intent. And unfortunately, as we're a one-man band, we can only have patients who have been treated at UCLH or North Middlesex Hospital at the moment. Thank you. Oh, sorry, one thing. So what we wanted was our patients who said, my life was worse than when I was having treatment, to come back and say, I'm cured of my cancer and have a life worth living.
Thanks very much. Thank you. Thanks very much. And absolutely, we need that experience from patients. So are there any questions for anybody? You just pop your hand up, or if you can't make your hand function, then just put your camera on a wave. Thanks. So thanks. One of the things I wanted to ask, Federico, with the Consultant Connect at the moment, what proportion of the queries do you know are being answered by our local consultants? So
which type of queries we get? Sorry.
And which, so the staff Consultant Connect can come from local trusts, and they can also come from the national team, Consultant Connect team, so that there is, and the Consultant Connect team set it up so that the call first of all goes to the local team, but if no one is able to answer within a certain number of rings, then it gets transferred to the national set of head and neck consultants, so that there is some a response for general practice that's in real time.
Okay, yeah. Usually, so it works at UCLH, and Denise, the previous lead, we work with Andy quite a lot. So okay. At the moment, it would come. So we're looking into, how many referrals at the moment. Some GPs that I tend to see, because I overview all the requests that we get on Consultant Connect. It tends to be the same GPs trying to refer, and pretty much locally. But if I'm honest with you, and that's why we're trying to promote, we're not getting too many requests, okay, on a weekly basis. I would say sometimes we can get 1 or 2 one day, and then maybe nothing for a couple of days. So
I think we need to be using it more.
Yeah, because and once we know, once we have a real number and like a proper number of requests, we can think about how we're going to improve the service. At the moment, it's very minimal, and that's why I think it's a really, really important platform that we need to start to use and promote.
Yeah, I think the other good thing about it, as long as the response time is kept very short, like the initial concept, you can also do it in during surgery. And particularly if you think that you're going to be advised that the patient doesn't need referral on, but needs to do X, Y, or Z, it's really powerful for a patient here.
Usually it's pretty quick. So we had, if you go on the page, there are a couple of examples that we shared with the Consultant Connect that usually we tend to reply within the same day, if it's not weekend, obviously, or in 1 or 2 days. There have been a couple of cases where, unfortunately, the option wasn't showing up, so the message wouldn't sit would then really show up. But yeah, absolutely. Usually it's really short, within the same day most of the time.
Okay, but that can Consult Connect or e-consult.
Consult
Connect can be quicker in real time, so it rings and it trips over in 30 seconds to the next consultant answering the call. You're having that as well, are you? You're offering that as well?
Not technically at the moment, as we're working with the platform here at UCLH. We tried with the number, but we had it's mostly a messaging app at the moment. So we get the message and then we get notification. If we're able, sometimes, for example, if I'm screening, if I'm not in clinic, I can reply straight away after a couple of minutes. Okay, but sometimes
it gets so we may need to look at it, maybe because once the immediacy changes, it changes how people use the service. Got a question here. Malavini, hi.
Hi, sorry. I was just wondering, do you have any experience in the referrals coming to the wrong specialty? I mean, this is something very common with head and neck. Our staff doesn't know, and it goes to thyroid, goes to ENT, ENT goes to MaxFax. So what's the work around in this, and how do you tackle? I mean, I know I try, but the locum doctors and the staff, it's always a mess.
Okay,
yeah, we tend to get, inappropriate referrals, unfortunately. Sometimes even, for example, even the wrong form. Sometimes we tend to get referrals from a neuro point of view, patients that should be referred to the neurosurgical team, or sometimes ophthalmology as well. As a rule of thumb, I would say, like the page dedicated to the MaxFax is like oral cavity masses, probably mostly with the oral cavity, mandibular region. But most of the other cases will come to the head and neck ENT. Because if you look at the options, any nasal, ear, and that's why I showed the other slide, because some of the referrals are really pretty benign, so we shouldn't be seeing them in the head and neck cancer clinic. As you can imagine, it can increase the backlog, and I know it's not easy, and managing patients' expectations, but for some of them, sometimes we're basically just delaying the actual appropriate referral. So they come, and then we need to send them to otology or rhinology.
Okay, so I guess at the moment what's happening is the system, Malar, is managing that, but do you think it's just a question of education, or is there other things that we can do?
I think it's education more around the admin team. And I know and also clinical team has to be aware that they have to give clear instructions to the admin team.
Yeah, so there might be, we're looking to involve some of this, incorporate some of this kind of teaching into our new education platform. And that platform is specifically designed to have slightly different levels of education for clinicians and non-clinicians in primary care, and the varying levels of clinical seniority in primary care. So I think that we can really think about doing something for our admin teams, and we also bring together practice managers across the whole of North Central London. So it may be that if you wanted to put something together for us to share at the practice managers meeting, when they're actually talking to other managers and other people that manage admin in primary care, just to kind of, third of a page thing, or it's like really short to say the next service is actually, is this, and that's different from X, Y, Z.
Absolutely.
I think it's our mistake as clinicians. We should be more careful in instructing, but we are not doing it properly. But thank you.
And can I just ask if somebody is using the advice and guidance for referrals, the one that I showed at last? Because this is something that probably in the next couple of years is going to be developed quite a lot, because the plan is in the plan for digital transformation of the NHS. And I don't know if anybody's got experience with that in terms of using it for advice, and even with other specialities, just for my knowledge.
Does anybody?
I use a lot of advice and guidance so that we avoid referral, especially if something like simple, what do you want me to do next? What medication is safe here? Or but this consultant connect and the app getting the message is something new to me. I use the consultant connect to talk to consultants, but not to message consultants. So maybe that's something I have to explore. I have the app, but I have to explore.
I think it wasn't initially conceived as a talking, as a trial, and one of the really important things is obviously not what you're able to offer yet through the staffing, but is actually needs to be real time. So I think the evidence around it shows, or around using the e-consulting, is that the fact it's not in real time ultimately reduces the impact on services, whereas it has in real time. It actually stops, ensures that people get seen in the right place at the right time and stops unnecessary referrals. But once it's happening, the response is later, people start to use it less and less, because the way people work in general practice now is that a lot of people are sessional, so they want to finish their work at the time in that session, and they don't want it hanging over.
I see.
So e-consult makes things hang over, which is difficult for the staff that are only doing certain sessions in each particular practice.
Okay. Yeah.
So I think I would suggest we need to look at the other option, and the one option you can make is that instead of getting your team to reply in a day or by messaging, you could consider contracting Consult Connect to provide that aspect of the service, where they'll provide a continual telephone service. So your named staff get contacted first before the forms, and in a couple of seconds that then it flips to someone else.
Okay.
And the feedback we
interesting
get,
to know.
the feedback we said for GPs is that in the main, although it's best and nicest to speak to somebody that is working in your area, in your geographical area, it's been helpful, even if the consultants from the other ends of the country.
Okay, really interesting. Yeah, thanks.
Hi, sorry, Federico. I was just going to share. I'm just joining to raise my awareness about the service. I'm based at North. Hiya. I'm based at North Middlesex Hospital, and we've got, you must know of Shelley, who's our head and neck consultant radiographer.
Yeah.
But it's interesting because obviously, if patients were to visit us after 6 months, we would refer back to Shelley, or would we refer? So, because I work in the Macmillan Information Centre. And often patients will come to us and say, oh, I've got some long-term side effects. We've got some wellbeing offers here, which might not be appropriate for head and neck patients, but there isn't any direct referral into the service from other sort of people that see patients. It's us. Would it be us referring back to our radiotherapy team to then refer to you, or?
Yeah, Sabina, what do you think about that?
Sorry, can you just say that again? I kind of have my lines breaking up.
So the question is how. I'll let Zeba rephrase it. Zeba.
Yeah, I was just going to say, is there any direct referral any services can make, or do you rely on the patients to visit the GP to make a referral into the late effect service?
So most of our. Sorry, go ahead. No, you go ahead.
I work at North Middlesex Hospital, and Shelley's our consultant.
Yes.
Head and neck consultant radiographer. So I'm only asking. I am a radiotherapy radiographer by background, but often people will come to our health and wellbeing events, and would we just refer back to Shelley, and she would obviously?
No. Anyone in the NCL network, as long as that patient has been treated at North Mid or had radiotherapy treatment at North Mid and been treated at UCLH, they can email us as well. So I can share the email address. We just need. The best thing we really need is like details of when they had the treatment, and then which hospital, just to make sure it's the one, and make sure they've been radically treated, because quite often we've had some rogue referrals, like some neuro referrals, things like that, just to screen it properly. And that's it. If they refer to us, and then we'll do all the hard work from there. We'll take it back, and I think the best part of it, is just communicating back with the GP. So rather than saying this is your problem or this is your problem, which I think quite often can happen, is working together to say, look, we've done this, we screened this, we found this. This might be now easier for you to do, or what information do you need? And actually, we've had loads of really good communication with GP practices. Understanding the nuances involved with survivorship as well. A really key one is that whole issue with dysphagia and recurrent chest infections in patients where actually it is due to radiotherapy physiotherapy and they need enteral feeding. So yeah, we work with anyone. So you can be OT,
Okay.
physio, as long as you're a healthcare professional, you can refer in as well.
Okay, so that'd be really useful just to get that link into referrals from our perspective, and we can share it with our staff that work within the information and support service. Thank you.
Thank you very much. Right, any more questions? Okay, we're going to finish now, I think. Thank you so very much, everybody. And just remember to tell your colleagues that this is available on our channel because we've recorded it, and we may well do a follow-up one once we get some feedback about that. So maybe diarise at different times just to help people make the meetings. But that's really been really helpful. I hope Frederica and Claire and Sabina, it was helpful to be able to get some feedback individually from GPs about what how their side of the coin works. But and when we come out, as we hope to do in the future with this education pack on our new platform, which will be delivered either on a handheld device or on a desktop. I hope that will be really helpful to you as well. Okay, so we're going to end today. Thank you again to everybody for joining us. And if you would like any of all of our webinars to fall automatically into your Microsoft Teams or Outlook diaries, what you need to do is to let us know that that will be fine, and then we will just routinely send any meeting that occurs on any day into your diary, and then you can join if you like or not if you can't. Okay, so thank you very much.
Thank you.
Thank you so
Thanks,
much.
Bye.
Thank you.
Bye
Bye-bye.
bye.